Hello, everyone, and welcome to the Parenting is Easy podcast, where we will discuss the pleasures and the frustrations, the good and the bad, and the rewarding and the troubling aspects of parenting. I am your host, Hananya Abraham, and I'm a psychotherapist that specializes in working with teenagers, young adults, and parents with a specific niche in assisting with communication within the family dynamics. While everyone has their own unique journey and experiences as a parent and as a child, there are many common affiliations and attributes that we can all relate to and share. Together, we will learn from personal stories and experiences from parents across many different backgrounds, cultures, and communities. So get comfortable, grab your glass of coffee, and let's get right into the interview.
Welcome back, everyone, to another episode of Parenting is Easy, Said No One Ever. I am your host, Hananya Abraham, and today, like we have talked about before, we have an amazing interview that's going to be very helpful to us in a specific category that we have not yet discussed here on this topic. Dr. Stephen Hodges is a professor of pediatric urology at Wake Forest University School of Medicine, is a leading authority in childhood toileting issues. He is dedicated to debunking the common myths surrounding bedtime and daytime wetting, and we're going to talk about that today, as well as debunking poop accidents, emphasizing that these issues are never a child's fault. Dr. Hodges, residing in Winston-Salem, North Carolina, with his family, has authored 8 books for both parents and children. Dr. Hodges, thank you so much for joining us today.
Thank you for taking the time to talk about this topic. I appreciate it.
Yeah, I think this is really important as a parent of a few young little kids over here, and in making sure that I'm setting them up properly for what they need for themselves, as opposed to what I think they may need. I'm curious, what are some of the things that come to mind regarding how us as parents can prepare more for making sure that our children are going to the bathroom properly, whether it's foods that we eat, whether it's a certain behavioral or even mental aspect of things that parents should be knowing that we probably don't know when it comes to making sure that our kids are going to the bathroom properly.
Yeah, I think one of the things that's unfortunate is that there's a perceived kind of badge of honor for early potty training. And so some parents will think, look how bright my child is, they were potty trained at, 2 or younger. And then once they're holding their urine successfully out of diapers, then the parents check out a little bit in terms of monitoring how they're going. And so as you can imagine, if you give a 2-year-old complete responsibility over a certain task, that task may not be done, appropriately. And so what ends up happening is these kids what it means if you toilet train early is that the child's got good sphincter control, right? They can hold things in easily. And they tend to overdo it, which is kind of going to be our theme today. And so then they hold in things over time. The body just reacts with accidents. And so what started out as you thought was a blessing, this early toilet training, ends up being a kind of a curse, the accidents that may be difficult to treat at a later stage.
Wow. So you're saying the longer you wait, so to speak, the easier it'll be long-term regarding how they're going to work on those muscles to make sure that they're urinating and pooping properly.
Yeah, I'd say that in general, freer emptying is better health-wise for kids if they can pee and poop freely. And the most free way to pee and poop is in pull-ups or diapers, obviously, because there's no barriers. Once you establish barriers, it becomes a little more difficult. And those barriers can get progressively worse as they start wearing kind of more adult-like clothes with pants that buckle or zip, or, girls might wear fancy dresses. It's kind of hard to get out of that. And then they might be placed in an environment maybe where the bathroom is a barrier, where maybe the bathroom is scary or dirty, or kids pick on them, so they may not want to go in public. So the longer you can keep them kind of freely emptying, the better. And then if you're always emptying and not kind of retaining poop or pee, it'll be easier to train when you want to train. And I used to be pretty dogmatic about that, saying, look, train later, it's better, kind of take it off your plate. But I realize some families have some mandates from schools or other issues that maybe force them to train a little earlier. And so I'm more open to it as long as you keep track of how they're emptying and keep on top of it. And the reality is the kids that withhold have to have a genetic predisposition for accidents. A lot of kids that train early they don't have the genes for bedwetting, for example, which we can discuss, they may not wet the bed even if they get backed up. But in general, more regular emptying, complete emptying is a healthier habit.
So I guess let's back up. I think there are a lot of things to sort of unpack with that. So first, when it comes to the type of underwear to wear, and then how that actually assists in the child knowing they should be going to the bathroom. So first, are there specific things that we should be putting on our kids? Are there certain ages that we should be changing? Going from regular diapers to pull-ups or to underwear. At what age should that be starting? Are there certain things developmentally that we should be looking out for that we can sort of have as a sign that, okay, now it's time to transition to something else? And what does it mean to fully empty as well?
Yeah, so I'm not a big believer in the put them in something that they will feel the wetness in and they'll learn, because when they're wet or when they've had an accident, the horse is out of the barn, so to speak, the accident's already happened. And so the accidents happen in children that have constipation, which we'll talk about, and they don't really feel the accidents. So one of the universal traits we will see in parents of children with accidents is the child, walks around with wet diaper or underwear and has no idea they even went. So not a big proponent of changing what they wear to promote toilet training. My point was rather that they have to have certain physical developmental milestones met, such as, can they get to the bathroom? Are they able to dress and undress themselves? If it's, you don't want to, can you imagine a little kid getting out of overalls or something, more difficult than if they had something they could just pull down, like jogging pants and pull up. So when potty training, whatever age you do it, I would look at how many barriers you can remove to the child going to the bathroom easily, because they're looking at it from a kid's perspective, not ours. We assume that people would just go to the bathroom when they need to. They look at it more as an inconvenience, and the more inconvenient it is, the less likely they will do it on time, and they'll just squeeze their sphincter till the urge goes away and then go about their business. And they don't understand that, it doesn't just disappear. It's still waiting to be emptied. Yeah. So
on that point of when it's time for a kid to start training, what signs can us as parents look for to say, okay, now it's that, transition times that we should be making sure to have those clothing that are easy, accessible for them to take off so that they can go to the bathroom? And are there certain ways of delivering it to a child that this is the next thing we're going to do? This is you becoming a bigger person, and developmentally, which obviously it's being a big change. I'm curious, what can we say to our kids that can make it something relatable to them from their point of view, like you're saying?
Yeah, and that's a good point, is that you're implying that we're talking to the children, which means they can understand it, which means they're at a certain age where they can understand conversation, right? Because some kids are trained so young that they may not even be able to communicate well. So what I've seen personally, anecdotally, as well as in my clinic, is that anytime before 3 appears to be a little bit too young for developmentally normal children, just because even though they maybe have the characteristics needed to do it, they don't have the level of understanding, can't really communicate well with them. And then 4 and older appears to be a little too late, because they're the kids that can't train then usually have an issue with the ability to train, maybe because they've been constipated already, or maybe have other issues, or maybe they have some hang-ups about potty training, but by 4 they should be able to potty train. So we kind of settled on 3.5 for most kids as a good age to introduce it. And we do a little bit of a soft sell. We just put out potties and recommend, hey, if you want to go to the potty. And traditionally we've seen kids urinate in the toilet a little bit sooner than pooping in the potty. And pooping is definitely the theme of today. Will be that pooping is difficult for kids, and they start withholding pretty soon. And there's a lot of tricks we have to use to kind of get them to defecate normally, on time, and regularly.
So on that point, though, of potties, I got to say, you say that word and I squirm. I've already very successfully trained 4 kids, and I have one more on the way. We've got training coming up, and the concept of having a potty is just like, I clean enough stuff, man.
Yeah.
I have to clean something else, and I'm just and it's worked well for the past 4, and I feel like now I have to start with a potty, something else like to be training in. Like, why not just go to the real thing? So
yeah, I like the idea of them being everywhere, around. So the kid doesn't have again this kind of theme of barriers. But yeah, it's you're not mandated to use an extra one. If they can have the little step stool that gets into the regular toilet with a seat, that's fine as well. Yeah, I feel you. There's enough to do already during the day.
right, but I understand what you're saying regarding to bringing down the barriers to make it accessible. So
Yeah.
on that point of obviously urinating is going to be very different than them sitting on the toilet and feeling. Obviously, it's a different sensation, different muscles used. Are there certain things as parents that we can sort of look out for to say, maybe this child is now ready for the next stage, which obviously be after urinating, being able to sit on the toilet and pooping? What is that stage? What should we be looking out for?
Yeah, you'll see them. So one of the interesting factors that there's a real common characteristic among children is that they will hide to poop. But hiding is definitely associated with constipation. Because think about it, if it's that much in your head, that you've got to go get in a location where you can be to yourself and kind of force it out, then you're thinking a little bit too much about it. I tell families I like to see the child, they'll be playing, pause, poop, keep playing. That's a good sign. When they're at that point where they're pooping really without a negligible strain on their psyche, then that you can introduce the toilet to those kids and they do better. The kids that are hiding, red face, squatting, trying to fight it, delivering a baby, so to speak, every time they poop, that's a sign that first, before you do anything, you need to get them pooping regularly before you try to potty train, because those are warning signs.
So, but even before that, because I'm thinking like my 2-year-old is very good at he has his spot in the house where he likes going to, and but at the same time I also feel like 2 is very young to be training because he's not ready and he doesn't get the concept. So like, what's that balance regarding seeing him do these things and be able to differentiate of, hey, I'm doing something and I need my place to be doing it in. Yet at the same time also taking a step back and saying, well, maybe they're not ready for this. Like how as we as parents, how can we differentiate like what the child is going through on the inside for how we should be treating them on the outside in the real world?
Yeah, I think 2 points. One is that independent of that, look at their age. And again, I hate to put a hard number on it, but you said the same thing kind of. 2 years old is a little young. You from other interactions you have with them that you can't really ask too much of him. I'm sure he's very bright, but it's just he's 2 years old. So even if they're pooping, even if they're ready, there's no rush here. You want to set good habits, and I understand my perspective is from treating when it goes bad, right? So I'm sure there's lots of kids, parents that potty train 5 or 6 or 7 kids and never have issues, and that's great. But in my world of how do I prevent people from showing up in my clinic 5 years later with accidents, any kind of signs of, okay, he's got to go in that corner to poop, it's in their head a little bit. And so I know that if it gets any firmer or maybe a little more uncomfortable, then it might be a little bit of an issue. So look at the poop. Is it huge, or is he putting out these huge logs? Is it very wide in diameter? Is he straining a little bit? And can we do anything to make it a little easier on him? So maybe, he doesn't go to the corner anymore. He just kind of pauses, poops, and goes about his business. I just think when you get it out of their head is the best way I can put it, and it's not even something they think about that much. They just do it. Those kids do much better with potty training.
Okay, and you're saying that even if that's happening, let's say at a little over 2 years old, let's say at 26, 27 months, that might be time, even though it's on the younger side, but it's not really, because that means the child in some ways is ready for it. Now, you talk about some things to make it that when they're having a little bit of a hard time to be going to the bathroom and them pausing, going to the corner, and maybe having a little bit of pain and talking about it and saying something. What are there foods that we can either bring in to the daily life of the child and maybe the family and overall, or that we should either be having and you would recommend, or maybe we should be staying away from when it comes to making sure that our children are going to the bathroom the way they're supposed to?
What we typically see is that changes in diet are a big contributing factor to the change in the texture of the poop, and then change in how they feel it, and then whether or not they're going to hold or not. So the child's born, interesting, if you look at newborns, a lot of them will strain to poop. It's called a condition called dyschezia. And they think it's when going from maybe passing a little bit of meconium in utero, where, happens maybe rarely, but does happen a little bit, and then going and doing that in the outside world, it's a strange sensation. And so human beings are very smart, obviously, and so they react in a way that's a little bit unexpected. I remember my oldest was just having the hardest time pooping, and a GI buddy of mine was like, just put a little thermometer in her bottom, and I don't even think they recommend that anymore. But the poop would come out like mustard. I'm like, what are you complaining about? This poop is completely soft. It's just the sensation of passing. This early mustard poop was strange to her, and then. So kids pass through that dyschezia phase, and they have pretty normal poops if they're on formula or breast milk. Usually not much issue because it's pretty consistent. But the moment you change things, whether that's adding rice cereal, adding dairy, adding table food, maybe they had an infection, they had some antibiotics.
What do you mean by table food? What do you mean by
yeah,
food?
Just like potatoes, rice, meat. You start giving them real food, adult food.
Okay.
That's going to change the consistency of the poop, and we see the opposite too, where if they're having regular poop, they get an ear infection or something, and they get put on antibiotics. They have diarrhea, and they go from diarrhea to back to normal poop. Those changes really can cause a holding reflex. So anytime you see that, you have to be aware of it and make modifications. Again, I've been through all the diets, and I've seen so many kids with cleaner diets than I would even think is possible. Right? These parents, I don't know how they had the time to prepare this meal. Get backed up, that I don't, I would never not recommend a nice whole food, high fiber diet, because that's the key, right? That's probably what's gone wrong with modern humans, is it's such a processed diet that we can't really even poop normally. But it's just so hard to get there that the real world answer ends up being, some osmotic laxatives, just because you can, because you're just trying to get your kid to eat healthy calories best you can. And as they become more picky, getting a child to eat enough fiber to have comfortable bowel movements it's a struggle. And again, I say diet's important, but I think personality and genetics are more important, because I've seen kids eating, again, meals that you couldn't believe how much time and planning went into these meals, how healthy they are, and they still just don't want to poop and they hold it in. So do the best you can with diet, but always make up the difference with other products as needed to keep the kids moving is my philosophy.
What do you mean by genetics, and how does it come into play regarding our kids' bowel movements?
Yeah, so I look at like the concept of anal retentiveness, right? How likely are you to withhold poop if you feel uncomfortable? And I can't begin to explain the personality traits that cause that, but I just know it. And so, classic example: if I'm in my clinic and I see a child that is severely constipated, and I just look at both parents and I'll say, look at the one that looks like him or looks like her, and I'll be like, hey, I bet you were constipated as a kid. And they're like, oh, I was. And so you just see this trait, and it's not like we evolved constipation genes. It's just that some people, whatever their way their brain's wired, they're more likely to squeeze their sphincter if they have an uncomfortable bowel movement. And other kids will sit there and just force it out, But it's definitely genetic in that manner speaking. And so once I get a lot of kids better from their accents, and we're through this process, and I'm graduating from my clinic, often say, okay, remember when you have a kid, make sure they're pooping at a young age, because I do see it repeat itself over and over again.
Is there a certain amount of time if a kid is sitting on the toilet but nothing's coming out, that as parents we should be like, all right, maybe let's go do something, maybe distract ourselves a little bit, get out of our head, and then come back? Is there an amount of time that is considered quote unquote normal for a child?
Yeah, that's a good point, because the way we're designed to empty is you get the urge, you go empty, you're done, right? And so a lot of what happens with kids with accents is that doctors or parents will say, okay, we're going to sit you're having accents, we're going to sit on the toilet every 2 hours so you pee. And it doesn't work well because there's no urge, right? It's out of the blue. It's very difficult for children to initiate an emptying without the urge. And you're learning bad habits too because they're not responding to the urge. So one of my favorite facts that I tell kids, and some kids really run with it, is that it takes the average mammal 12 seconds to poop. And so you feel it, you go sit on the potty, poop. I don't know who did that. I don't remember where I read it, but it stuck in my brain. And so if you have these families say, well, he spends an hour on the toilet, well, that's obviously wrong. It shouldn't be a process, shouldn't be difficult. I mean, if after meals, if you want to have them sit to see if something comes out, that's fine. And some kids, they sit to pee maybe, and they didn't even realize they had to poop, and they are able to poop. that's fine. But in reality, you should get an urge, respond to it, and be done. And it shouldn't take much time at all.
Squatty potty. Is that something that you would recommend, especially for kids that are looking to have the right posture? And even for adults, is that something that should be used?
Yeah, I definitely, we work with them actually. I remember for some children's themed potties, I think the best way to poop would be kind of an air squat position, right? So you're squatting down, but your bottom is not resting on anything. But that's like, I don't think Americans can even do that. It's just like a high level physical move. But raising the knees to the chest is very important. I know two examples of that. One is kids with rectal prolapse, which is a condition where they strain so much that they actually evert the rectum out of their bottom. So the intestines everts out. It's a consequence of severe constipation. One of the ways that doctors recommend preventing prolapse happening in children is really knees to chest defecation position, which is relieving the pressure enough that the poop comes out easily without straining. So you can imagine lifting the knees by placing the feet on a stool can mimic that. And another I read once, a mom, she said, which ties into that, is every time her young infant had trouble defecating, she would sit kind of crisscross applesauce and then kind of dunk the child's bum in the hole there between her legs. So it's almost like imagine a kid that fell in a hole and they accordion their body, their knees at the same position, and that child, she said, would always poop easily. And that made sense to me because they were getting in the same position as this kind of knees to chest position for prolapse. So something about that position helps emptying happen at less pressure.
Yeah, what's coming to mind for me is I guess getting to that cannonball position before you jump into the water.
Yeah, exactly. Yeah.
On the toilet, I think could be helpful for a child, and obviously help with maybe the core muscles as well, as the child is sitting there for hopefully only 15 seconds or
exactly,
less.
Yeah.
In that sense. And you remind me of something else that I used to do with my little infants is, hold them by their back and hold their feet, sort of bring their knees to their chest and like in a sitting position, like midair. So, and when they started making those noises that you knew they were trying to go to the bathroom, it would be that sitting position. I guess it's the same thing as sitting crisscross applesauce and putting the kid inside.
Yeah,
let's say that same concept, and that movement can obviously be very beneficial for the child and obviously for adults as we make sure that we have the right posture when we're on the toilet. You've talked about, and I'm curious if you can add to the concept of constipation and bedwetting and what the correlation is between the two. Can you talk about that for a minute, please?
Sure. And I want to start out by clarifying what we mean by constipation, because I think that's one of the semantics and the definition of what constipation means has been one of the main causes of bedwetting being, I think, undertreated in children. So when adults think of constipation or functional constipation, they think of rare bowel movements or hard bowel movements. And unfortunately, children may not present that way, so it may be missed. I think that the only consistent trait we will see in kids that's, across the board will be larger bowel movements, because what we're treating is delayed emptying of the rectum. So kids put off pooping. So you got to poop right now and it would come out easy, but you don't want to because it's not a good time. So you hold it, and then you got to poop later, but you want to hold it. And so by the next day you finally go, you have so much poop out in the rectum that not only do you put out a large wide bowel movement, it hurts, it's painful, and then you probably don't get it all out, which is incomplete emptying, kind of back to that topic. And so you end up with that kind of behavior, eventually leading to this overly distended, overly full end of the colon, which is called the rectum. And since the rectum is a sensing organ for fullness, which happens via stretch, if you constantly stretch it or always leave it stretched, you lose a little bit of the sensation of when you need to poop. So you end up sitting there with a lot of poop in the rectum. You may not even feel it because it's been stretched like that forever. And that stretching in the rectum starts impinging on the nerves that go from the bladder to the brain. And those are the nerves that control whether the bladder is full, retains urine, or empties urine. And what it can do, a large rectum, is set off a reflex void, which is just an automatic emptying the bladder, which probably doesn't even get to the brain. It's just kind of like a loop reflex. bladder to the rectum to the spinal cord back to the bladder. And so you empty the bladder completely without any awareness in your brain, which explains why kids can wet the bed and not wake up, or kids that have accents while awake can have an accent and not even know they had an accent, which is pretty consistent in our clinic.
Wow. So in general, it sounds like the less the brain is working in a certain way, the better chance for the muscles to relax, with better chance of actual the relief to be there internally, and therefore that's where our accidents would happen. So how can parents create that environment in a way where it's being done in the toilet and not in a bed?
I would say that if we go back and forth on age, so I usually say 4 years of age, maybe into 5 is an age where bedwetting shouldn't be happening anymore. And so if you have a child that's wetting the bed, don't worry about anything other than addressing the bowel movements, because if they can't retain urine, then most likely that reflex is being fired off by this rectal dilation. And so if you have a kid that's 4 or 5 years old, wetting the bed nightly, oblivious to it, don't know, they don't wake up, can't wake them up easily, seems like a large volume, a lot of these factors start influencing parents. They think, well, they're too sleepy because I can't wake them up. There's too much urine because the bed's soaked. In reality, it's almost always this bowel issue. You could get an x-ray if you wanted to document it, or you could just start them on some type of laxative or enema or suppository program, empty them out, and you'll see this gradual lessening of the wetting until they're completely dry. That's the key.
So a parent should be on top of this already at the age of 3 years old, just to be wary of the things that might happen outside of the bathroom when it comes to their children. And there are things that they can do or maybe even give that can really help the process, but they shouldn't be worried that this happened, because in some ways it sounds like it's more normal than we think, and it's more common for there to be things that we can do just based on what there is out there. So I guess, going back to the question I asked before, are there certain either foods that we can give our kids that can be beneficial, or maybe there's certain ways of talking to our kids that it's relatable regarding the concept of peeing properly or bowel movements properly, that maybe the language is something that we can better understand and know? Are there certain things that we can do?
I foods, it's going to be a trial and error because everyone's so different. Everyone knows, high fiber is good for bowel movements, but sometimes if there's too much fiber without enough fluid, it can make it actually bulk things up a little bit. So you have to look and say, okay, when my child eats blueberries, they poop. Okay, if that works for your kid, can you give them blueberries more regularly? Can you, if they eat cheese, they get backed up, can you avoid the cheese or use it sparingly? So it's kind of trial and error. I think that it's not it could be seen as a cop-out, but I think that what I've seen, if you have a child that's getting backed up, like let's take one of my daughters that got backed up with rice cereal, at that point, what are you going to do, right? She's getting formula and rice cereal. How can you change your diet? But I knew that retaining poop or learning that habit was going to be a bad thing long term. So I started, Miralax at that age. I talked to my pediatrician, made sure she was on board, and we started and kind of immediately kind of restored this normal mushy poop. And that holding behavior only lasted a week, and then she was back to normal. And we kept her on it, and she did great. And she had this added benefit of not caring where she pooped. She was really easily pooped in public, and she never developed, again, these hang-ups about the discomfort involved. Some people may not want to use laxatives, and I'm not saying you have to, but I'm saying finding the right diet is very difficult. Talking is also very difficult because it's one of these concepts that you can't really reason through with kids. Like if I told a child, okay, listen, you have to poop on the potty, or if your poop hurts, you really got to let it out. That sounds great until they're in, what's the old Mike Tyson thing? Everyone's got a plan until they get punched in the face. Yeah, you can be like, okay, I want to poop. The moment you go poop and it hurts, it's out the door. So what works better is creating the proper urges, make sure the poop is soft, so then when you go, oh, that was actually a relief. Building these habits of like the way it's supposed to work. Because if every time they go poop, it hurts, we're humans. We're going to avoid that. But if you can make it feel comfortable by any means necessary. And I'll give you a good example. There's certain kids that won't poop on the potty, right? They just won't. If they get the urge, they'll ask for a pull-up or they'll go in the corner or whatever, but they're not going on the toilet. And some people will keep them bottoms off to help encourage going on the toilet. And if the urge, as it comes on, for their brain, might come on a little just too subtly for them to make a difference. So there was a doctor, Dr. Dom, that came up with a strategy, and it works great. He said, well, I'm going to overwhelm the urge. I'm going to give them an offer they can't refuse. And so he would give these high doses of X-Lax. So this urge comes up, and they're like, man, this poop's coming. There's no stopping it. And those kids, they poop on the potty because they know it's coming. And it not only do they poop on the potty, it flips a switch in their brain that changes the stimulus response pattern to feel the urge to poop, go poop, away from feel the urge to poop, squeeze my sphincter to hold it in.
Hold it in.
Yeah, exactly. So You got to watch that process and see, because some people just need a lot of stimulus to go.
Yeah. Okay. So on this topic though of the constipation, I know you talked about certain signs that that parents should be looking for. I know you're talking about some of them, but can we go through like I don't know. I think you have somewhere like 10 or 12 signs that you talk about that parents can really look out for, and does it also make a difference on age for the different types of signs that we should be looking for?
Again, the most common one I would put and take to the bank would be the large diameter bowel movements. That's the key, because again, 2 centimeters is the average diameter of a normal bowel movement. So if they're putting out, parents say, oh, it looks like an eggplant. Why is it that big? Because it's been stuffed into the end of the colon for so long, it molded to the size of this colon, and then you had to force it out. Wow. So that should be obvious. It's not obvious to most people. The typical ones of rare bowel movements, obviously hard bowel movements, pebbly bowel movements. But then there's also the subtle ones of many small bowel movements. If you have a child, they should, if they have to poop, have a large bowel movement in terms of volume, not diameter, be done for the day. But if they're putting out smears all day, small smears, that can fool folks, because they think, oh, they're just pooping soft, small bowel movements, but they're just trying to get it out, and only the soft stuff's coming out. And then paradoxically, diarrhea sometimes. If you have chronic diarrhea in a child, and they're having other accidents, it's worth an X-ray, because there can be an impacted ball of stool, that liquid stool is going around. So in general, if you have signs that we correlate with constipation, whether it be belly pain is common in kids, but other things are poop accidents, pee accidents, bedwetting, UTIs in girls, think of constipation as we define it first and have it evaluated, and an X-ray is one of the easiest ways to do that.
Okay, and once the parents get an X-ray, what are the next steps? What are we supposed to be doing then?
Here's where it gets a little complicated, is that radiologists don't typically comment on poop in an X-ray, right? They're just like, normal stool gas pattern, normal skeletal structure. And so you have to say, okay, this child's having bedwetting. Let's look at the X-ray. Is there a big ball of poop in the rectum, which is the end of the colon? Your doctor can show you that. And if they do, then you're like, okay, there you go. How do we treat this? And so you have to get on some kind of program, whether it be oral laxatives or, I know it sounds strange, people use a lot of rectal therapies, kind of bottom-up approaches to empty it out. And the reason we do that is because, number one, that's where the problem is, right inside the rectum. And number two, there was a doctor in the 80s who we kind of modeled our program on, named Dr. Shauna Regan, that came to the same conclusion and used those enemas on children very effectively to treat these problems. Because again, you have a long pipe, so to speak, which is the colon, and the clog is at the end. So you can try to unclog it from the top, but it's a lot easier to unclog it from the bottom.
It sounds, I guess, very, very explicit regarding what we should be thinking about. But I think for what the next steps are when our child is going through this, that's obviously, I think it can be helpful for parents to know. That being said, are there long-term things that we should be looking out for? How things, when they start out young, whether it's 3-4 years old, and even as they get into adolescence and stuff, that could be long-term effects of constipation in a child.
Yeah, and I would say to that previous point that if you start earlier, if you jump on it right away, it's going to be a lot easier to treat, right? So maybe you can just add diet changes or a little bit of Miralax or something, and you won't have to go through the regimens that we have created for children that are severely constipated. But there's Dr. Regan linked several kind of bladder conditions, honestly, which is how I got into this as a urologist, related to constipation. So daytime incontinence of urine, nighttime incontinence of urine, poop accidents or fecal incontinence, what we call encopresis, urinary tract infections in girls, and another condition called vesicoureteral reflux, where in boys or girls they can have UTIs with fever, it's called pyelonephritis, where the urine is actually flowing from the bladder back up to the kidneys which is aberrant way. It's supposed to all come out. And so all those traits have been tied together in this global diagnosis of bowel and bladder dysfunction. But what that really means is that retained poop causes rectal dilation, which then leads to bladder dysfunction. And so all those traits can be improved. Outside of those, because there's some kids, honestly, that get very backed up and just the way they're made, they don't have accents, but they may go to the emergency room for belly pain. And I have this kind of, all the algorithms in medicine you learn, you kind of simplify them for your own practice. And so a kid comes in with severe belly pain, I think of one branch, constipation or appendicitis, it can be more complicated than that. But if you touch their belly and they jump off the table, probably appendicitis. If you touch their belly and they don't jump off the table and they feel full of poop, constipation, because stretching of the colon is very uncomfortable, causes bad pain in kids, and can lead to severe symptomatology.
Wow. So there obviously is so much there that, I think we can know, or that we should be knowing as parents when it comes to constipation. We talk about, also communicating to a child. And I think one of the things that, that we haven't talked about, but you've written a few books on this topic. And I'm curious, when it comes to relating to a child a story or something that could be relevant, what are some of the things that you've done, that you've written about, that can be of benefit to how we would be giving over things to our children?
Yeah, two things we've tried to encourage. One is to take off the blame for accents, because again, these children don't know what they're doing when they withhold their bowel movements, and incontinence is very frustrating for parents, right? So if you have a child that has accents every night, you have to change the sheets, or they're pooping on themselves at school, or even the step prior to accents where they may present with maybe frequency, having to pee too frequently. You go to dinner and they pee 10 times at dinner, or urgency, where they tell you what seems like the last minute that they need to urinate. Instead of looking as a child is making bad decisions, think, okay, what about the child's body is causing these symptoms? And it's, again, going back to this rectal dilation, and then treating that, because otherwise it'll drive you crazy, and it can lead to, in extreme cases, abuse of children, which is obviously the last thing anyone wants. And I would hate for a child that doesn't know what they've done wrong, can't control the accents, to now be punished because they can't stay dry. And then the other thing is, too, is what we try to do through, and that's where the kind of bedwetting accents are not your fault book ties in. The other book, Jane and the Giant Poop, has been like, look, you eat this food, it goes through your body and it accumulates, and you have to let it out. You can't just hold on to it. It kind of moves through you. There's a popular video that we're not responsible for called The Poo in You, which is very good as well. But I think parents focus a lot on the importance of nutrition with kids. They teach them they have to eat right. They may teach them about exercise and being active, but they don't talk too much about elimination. So you want to give this concept to them that whatever you take in, it has to come out. If you squeeze your sphincter, it doesn't just disappear, it doesn't go away. It's still there, it's accumulating. So you want to get that out of you in a timely fashion. Very important point. Yeah.
You touched on something regarding the abuse, and something I was thinking about before. I'm curious the effects of trauma within the family dynamics, whether it's to the child themselves or witnessing amongst the parents or another sibling. What effect does that have on constipation or any other bowel movement issues?
I think that in my experience, if there's a condition like secondary nocturnal enuresis, which is bedwetting that showed up after 6 months of dryness, so the child was dry and then they're constipated. Then they start wetting the bed, and that's attributed to stress. And then there's a lot of circumstances where children have accents and doctors blame it on stress. And I'm not saying that stress doesn't cause accents. I'm just saying that no matter how you got there, if the child's having accents, they withheld their bowel movements. And so it's obvious, I think, to probably us, that if you have a child that's stressed out, that they may withhold more. But I don't like the use of stress as an excuse for accents in kids, and therefore they're not treating the backed up poop. Does that make sense? Like,
Yeah.
say, yeah,
It's not a blame game.
exactly, yeah. So the kids pooping on themselves and like, oh, they've been stressed. And the parents are, half the time racking their brains. What did we do to stress them out so much? And maybe there is some stress, but the kid, at the end of the day, the kid held his poop to get backed up to have poop fall out. So, let's put a child in a good environment. That's great, but let's also treat the constipation so they have a chance to get better.
That's okay. Yeah, that makes a lot of sense. I know there's so many more things, doctor, that I want to touch on over here. Just a few more quick things over here before we wrap it up over here today. I'm curious, as kids progress and there are things happening that it's not going well, and parents are obviously frustrated. And I think one of the things I'm taking out of today is that parents, we should be taking a look inside and realizing this is not our child's fault. I think that's one of the biggest things that I'm taking away from our conversation today. But I'm curious, what other resources are there? Where can people look in their local neighborhoods and maybe clinics where maybe the question they should be asking their primary care doctor when there are issues that are just prevailing and they're just constantly there? What type of questions should they be asking their medical professionals or urgent care places?
Yeah, I hate that this is the case, but unfortunately I've seen this too many times, is that because most accidents resolve on their own, and that may be in a year, or it may be in 10 or 15 years, doctors tend to not treat them, right? Because let's say you have a bedwetter, he's 5 years old. That would be about 25% of all kids in the clinic, and there's a 15% resolution a year. So it's much easier for the pediatrician, and I'm not blaming them because they're dealing with lots of problems, to say, you know what, are they pooping okay? Great. They'll outgrow it, and then maybe in a year, 15% of them outgrow it, but then maybe in 10 years, some haven't. And so as a parent, I think you have to be an advocate for your child and push the issue. Say, look, I understand that you want to take a wait and see approach, but I heard that this could be tied to constipation. Can we do something to look for that and address it? And I will say this about that is that, number one, I believe if you get an x-ray and you look for what we're talking about, you will find it. And if you treat it, they will get better. And then let's say the child is a circumstance where they're not constipated, which is rare. There's something causing it, right? And the small percentage of kids where accidents are happening and they're not constipated, it's a more significant problem. Maybe they have a tethered spinal cord, or maybe they have some kind of anatomic abnormality. So if you push the workup, hopefully and likely it's going to be constipation. That's easy to fix in theory. But if you ignored it, then maybe for those small cases where severe condition is being missed for a long time, you're really behind the eight ball. So I say, if you have a child that's incontinent, don't take a doctor's word of we're going to wait to outgrow it for, say, look, no, this is something, I appreciate your advice, but we really want to pursue this. We really want to treat it. What can we do to find out the causes?
Okay, so as we sort of, there's so many more questions I really want to ask over here, but I think there's one thing that stood out to me for something that you talk about regarding the M.O.P anthology. Could you talk a little bit about that and how that's something that we can really take into our family dynamics?
Yeah, so this goes back to the 1980s when Dr. Sean O'Regan, who I mentioned earlier, was a nephrologist in Canada, and his son was wetting the bed. And he says his wife was like, man, he's wetting the bed. Aren't you? You're a doctor. Can't you fix this? And he took it to heart. He researched causes of bedwetting, and he independently, putting all the physiology that was available at the time together, presumed that this would be due to rectal dilation, which is the theory we've adopted. And he's proven it. And then he said, okay, I bet my son has rectal dilation because of withholding poop. I'm going to test it. He tested his son's rectal dilation with a test called the anal rectal manometry. This is brilliant scientist, but definitely a scientist, because not many people would do this to a kid. You put a catheter up their bottom, and you blow up a balloon, and you see when they feel the balloon. His son didn't feel the balloon until it was 150 cc's of fluid in it, which is way too large. So he said, there, prove my theory. My son's rectum is dilated because he was holding his poop in. Now I'm going to treat that, and he's going to get dry. How did he treat it? He gave his son an enema every night, and his son was dry within a month because he fixed the problem. And he proved unequivocally that rectal dilation caused bedwetting. And that was the O'Regan protocol. 1 enema a night for a month, and then he tapered it over 2 months. We independently kind of discovered this correlation, then rediscovered his work. because I was a urologist. I didn't know how to use enemas. I was scared to death to use them. But once I realized he was doing it and it worked better, I jumped on with both feet. But we found that we saw so many kids now with so many problems, night wetting, bedwetting, poop accidents, that a month of enemas wasn't enough sometimes. So we made the modified O'Regan protocol, or M.O.P, and we've made several variations of it, of enema therapies, oral laxatives with or without them, all whose goal is the same: to empty the rectum as quickly as possible and as adequately as possible so that it can shrink back down to normal and the children can be dry. And that's basically the premise of the M.O.P Anthology.
Well, and let's say parents need to be doing something like that at home. What are they asking for within their clinic, wherever they are in the world?
Honestly, you can go to our website, www.bedwettingandaccents.com. We have all the resources you need. Obviously, if you're more comfortable doing it with your pediatrician, that's fine. But we're kind of on this point in history where we think, maybe 10 years from now, it'll be common knowledge, but right now it's not. And so you might get some pushback. Again, I don't want any parents doing anything they're not comfortable with, but be aware that if you go to your doctor and say, we've done a month of enemas in my son and he's wetting the bed less, the doctor may say, and we've seen this before, stop that right away. You're damaging your son, and the bedwetting comes back. So we have a lot of experience and data and research into the safety of enemas. We know how to do it safely, and we have that on our website. But it's definitely a controversial topic, unfortunately.
Yeah, it is unfortunate. I'm curious, you mentioned your website. Are there any other places you recommend, whether it's educationally or things that you would recommend people either read or look at, or people to sort of see more on this topic? What would you recommend for parents?
Yeah, and unfortunately, we're kind of putting all of it out. So, and everything is on that website. We have a list of all the books we published that you mentioned. We have a list of the research publications that we've made, as well as Dr. O'Regan's papers that tie into it. We have a list of medical practitioners that agree with and recommend M.O.P and all over the country. So if you want somebody close to you, and then we have a blog with just a lot of useful information. So and we have links to our Facebook page and kind of private consults. So anything you need, kind of the website's the hub, and you can go kind of do it on your own. You can do it with your local physician's help, or you can do it with our help.
Amazing. Okay. Thank you so much for that. I'm curious if there's anything that we haven't talked about today that really parents should be knowing when it comes to constipation and bedwetting that you would like everyone to know.
I would say this, that the more the rectum dilates, the accents tend to progress in this pattern. Bedwetting first. It only takes a little bit of dilation to cause bedwetting, which is why bedwetting seems so prevalent and so common and difficult to treat. And then you get, as it progressively dilates, you get daytime symptoms, whether it be frequency or urgency. And then you get daytime accents, which they don't feel, and then eventually poop accents. That's like end stage constipation. Poop is just falling out. So if you have a child with bedwetting and daytime wetting and poop accents, which some kids do, as you empty them out, the accents will go away in that reverse order. So the poop accents will go away first, the day wetting will go away second, the day symptoms will go away third, and the bedwetting goes away last. So a lot of parents will come into my office and say, oh, they're bedwetting, please help me. And we try to treat them, and they're not getting better right away. And I say, well, are you sure they didn't have daytime symptoms? They say, well, they peed all the time, but now that's gone away. I'm like, okay, that had to go away first before we got to the bedwetting. So I want everyone's kind of expectations appropriately aligned so they don't get frustrated with the process.
Yeah. Okay. So I think this is absolutely amazing. And one more time, just in case people don't have a pen yet, well, what is the website where people can find all this information and more about you and the work that you're doing?
Sure. www.bedwettingandaccents.com. I appreciate it.
And that's something that we will for sure be putting into the footnotes together with that video that you talked about of the poo in you, which is, I think, something that all of us parents should be watching. That could be really, really helpful, and that's I think something that really will be very helpful to us here on this podcast, and for parents, just to recommend to other people on this topic. That's really, I think, a very helpful video. As we sort of finish up over here, just a few rapid fire questions over here. So you talked about work or literature that on this topic. I'm curious for you personally, have there been any books that have really influenced both your career or you as a parent that you would recommend others to read?
There's a good a poop book, The Ins and Outs of Poop, by Duhamel. He's got a couple of different strategies on that tie in with ours in terms of how to get kids defecating normally. There's the Dom method. Dr. Dom unfortunately passed away. He had a website that treated encopresis called encopresis.com. There's a soiling solutions for constipation and encopresis by Dr. Collins. And then the rest is all scientific literature. It's Dr. Regan's papers. You can find, if you look up Dr. Sean Regan and read his papers, you'll know as much as I do.
Sean Regan, okay. Well, I don't know if we're going to know as much as you, but maybe we can hold conversation some way. I'm curious, has there ever been advice that you followed that you wished you would never have followed?
Yeah. And that it all relied to bedwetting. It's funny, like we talk about this with Suzanne a lot, is that there's a lot of book learning in medicine, but there's a lot of just like, hey, how do you do this? And people pass it on. So I remember being a resident in my residence clinic, and I had a child with bedwetting, and my chief resident, who didn't know any better because he's taught what we're taught. And so he goes, oh, don't worry about it until they're 6. And then once they're 6, you can give them some medicines or use an alarm. So I just learned this cookbook approach of kind of throwing things at the problem that weren't really based in science, I found out later. And so when I got into my own practice, I was doing this and kids weren't getting better. So I wish I kind of picked up on that a little sooner, and I'm glad we eventually kind of narrowed down the causes. But there's a lot of things, and it's made me more aware of maybe other areas of knowledge that I'm not familiar with. How much am I missing here, right? Because you can think, even a parent can look at bedwetting and be like, oh, I know what's causing it. They're sleeping too deeply, because it seems like that, but it's definitely not the case.
Yeah. Well, it's amazing how I feel this whole conversation comes down to something that has been talked so much about on this podcast, and something I talk about with my wife, and as a therapist, I bring it up with parents and individuals all the time, is communication. And that's really what it comes down to. And this is just a different form of it. And here it's just bringing a communication about constipation. And he has
no idea how many arguments that we've had with people over what is constipation. I mean, you could have a room of 100 doctors and not one of them would agree about what constipation means. And how can you solve a problem that no one can agree on what it is?
Yeah. Oh, 100%. Well, that's why hopefully, our listeners, I know for sure myself, really were able to pick up something regarding what it is, to be curious about it and to look into it, take matters into your own hands. Don't just, take the, wait until they're 6 or 7 approach and really do something. My last question for you as we sort of finish up over here, Doctor, if you can think of a mundane superpower that you would like to have as a parent to help you, what would that be and why?
Mundane superpower? Oh, I think I consider myself a patient man. I've made it through, residency and working in stressful locations, but nothing's as hard as being a parent, right? And so it's never a good look when you lose your cool, and your kids will definitely test you. So if I could keep that patience going, the patience I have for everyone else at work, if I could keep it at home, it'd be great. I always tell people work, you guys at least try to help me. I feel like at home sometimes they're against me. But yeah, patience would be the key.
Yeah. Oh, wow. That resonates with me. Well, Doctor, this has been absolutely amazing and so helpful and informative. Thank you so much for a few minutes today.
Thank you. Appreciate it for covering the topic.
Hey again. I hope you were able to learn as much as I did today. Thank you so much for staying to the end and listening to the entire interview. Please feel free to leave a comment wherever you listen to this podcast. All comments will be read weekly, and we appreciate all feedback and ideas. If you have an idea for a guest or a specific topic, please feel free to share. Additionally, you can contact us at parentingiseasypodcast@gmail.com. Again, that's parentingiseasypodcast@gmail.com. Thank you for joining today, and remember, parenting is a journey. Don't forget to enjoy it. The goal is to be a little better today than yesterday, and hopefully better tomorrow than we were today.